The use of ultrasound to screen for traumatic injuries had its origins in Europe and then spread to North America in the 1990s. This technology has mostly eliminated the initial use of diagnostic peritoneal lavage at trauma centers across the US and has been an integral part of the evaluation of trauma patients for over 20 years. The focused assessment with sonography for trauma, or FAST exam, is a goal-directed ultrasound protocol that has enabled clinicians to rapidly screen for injury at the bedside. This is relevant since traumatic injuries are a leading cause of death for those 44 years or younger. The FAST exam is typically used as the initial imaging exam on arrival to the ED and is part of the Advanced Trauma Life Support developed by the American College of Surgeons. The exam has evolved into a more comprehensive study of the abdomen, heart, chest, and inferior vena cava. In this lecture, we'll review the abdominal components of the FAST exam. It is important here to note that we will be fulfilling the requirements of the applied exam of the Objective Structure Clinical Exam Content Outline, or OSCEs, on the focus of the abdomen. Like all the lectures of this series, this review stems from current guidelines. A summary of the most relevant information is provided for ease of reference. We'll be reviewing the clips and images from the FAST exam at showmethefocus.com. Let's go. By the end of this lecture, you shall be able to identify or recognize the following:
the appropriate ultrasound settings, probe selection, and method of the FAST exam, the typical appearance of the intra-abdominal structures and boundaries, including the diaphragm, liver, spleen, kidneys, and bladder under ultrasound, identify free intra-abdominal fluid, make a qualitative assessment of fluid volume, recognize the accuracy and utility of the FAST exam in clinical decision-making, integrate the FAST exam findings in order to make an assessment of the differential diagnosis in shock, and recognize the limitations of the FAST exam for technical or anatomical constraint. Second, indications and performance. The main indication for the FAST exam is the suspicion of intraperitoneal hemorrhage, pericardial tamponade, and hemothorax. All these diagnoses can be identified by the presence of free fluid in any of those spaces. This is typically the case when there is blunt or penetrating trauma to the chest and abdomen. The FAST exam is performed after the primary survey of the ATLS protocol. This protocol has a major role in the triage and guiding diagnosis and management of trauma patients. In terms of the performance of the FAST exam, for blunt abdominal trauma, the study has low sensitivity, particularly in those patients who are hemodynamically stable. In these, the specificity is better at around 97%. This implies that we cannot use this technique to rule out an intra-abdominal injury in these patients. For penetrating trauma, it has a sensitivity that ranges between 28 to 100%. The exam does not detect bowel injury, which is common in penetrating injuries. However, its specificity is close to 100%. The exam is most valuable in unstable patients when clinical decision-making cannot wait for diagnostic studies such as computed tomography.
As perioperative physicians, we may not be directly involved with the initial protocols typically performed by ED and trauma physicians. However, there are two main uses of the FAST exam in the perioperative period and include the following.
When dealing with patients who initially came in as trauma and had an initial negative FAST exam and have now become unstable under our care, notice that this follows the poor sensitivity of the study, or B, in situations in which patients deteriorate after abdominal procedures, be it the operating room, intensive care unit, or the post-anesthesia care unit. Third, anatomy. The FAST exam evaluates potential spaces where free fluid can accumulate. These potential spaces are located in the pericardium, right upper quadrant and its corresponding hemodiaphragm, left upper quadrant and its corresponding hemodiaphragm, and pelvis. In a supine patient, the most dependent areas in the upper peritoneum lies between the liver and the right kidney, also known as Morrison's pouch. The most dependent area in the lower peritoneum is posterior to the bladder in the male and the pouch of Douglas in the female. The FAST exam. It is important to recognize that, like all POCUS applications, the FAST exam should follow the indication, acquisition, interpretation, and medical management framework. This allows us a standardized approach to minimize errors. We mentioned the indications of the exam. Now we move on to acquisition techniques that will assist us in getting the best picture quality possible. This is done to optimize the chances of correctly interpreting the images or clips. Patient positioning. The exam is typically performed in the supine position. However, the Trendelenburg position may enhance detection of free fluid in the right upper quadrant view by moving fluid up from the paracolic gutters. The same occurs, although to a lesser extent, to the left upper quadrant. Equipment and technology. The ultrasound machine should be set at the FAST or abdominal setting with the indicator on the left side of the screen display. A low-frequency probe is ideal for adequate tissue penetration, and thus the curvilinear probe or the phased array transducer should be the transducers of choice for the FAST exam. Linear array transducers are rarely utilized in the abdomen. Two-dimensional ultrasound is the only technology we'll be using for this application.
It is important to note that the FAST exam has evolved over the years and now also includes an evaluation of the anterior chest. This is known as the extended or EFAST exam that extends the utility of the protocol to include the lungs to look for a pneumothorax, in which case other probes can be used for this purpose. I have reviewed these areas of the examination of the lung and the heart, and links are provided in the description below for more information. The FAST exam involves an evaluation of the abdomen for free fluid, pericardial fluid, and assessment of the IVC. For purposes of the OSCEs, our goal is to focus on identification of free fluid in the abdomen. I explore these other areas with their respective lectures as part of this series.
Technique for image acquisition. We first need to define the objectives of the different views in our arsenal before we can move on to interpreting the findings. Image acquisition techniques rely on how you orient and manipulate the probe. For this reason, we'll be referring to the 3D model video clips available at showmethefocus.com, where we can assess the cuts made by the ultrasound beam as it interrogates a particular area of the abdomen. You can pause the videos on a particular view by clicking on the thumbnail. The sector depth should be set so you can see deep structures, so start by selecting a depth of around 16 centimeters. Right upper quadrant. This is the preferred initial site for detection of free fluid. It is the most sensitive and easiest to obtain in the detection of hemoperitoneum. The probe is placed in the mid-axillary line between the 8th and 11th intercostal space with the transducer's indicator pointed cephalad. This view gives a coronal view of the interface of the liver and kidney. Notice the typical echogenicity of the liver and that of the kidney with a hypoechoic or anechoic cortex and a hyperechoic medulla. There's also a hyperechoic facial plane covering the kidney. Here we visualize Morrison's pouch. The lower edge of the liver should be followed caudally until the tip or lower edge of the liver is obtained, as fluid will accumulate there first. Notice the acoustic shadow artifacts cast by ultrasound hitting the ribs in the near field. We can also assess the interface between the dome of the diaphragm and the liver, as well as the right pleural space by advancing the probe more cephalad. The interface of the diaphragm and the liver appears as a curved hyperechoic line. The normal lung movement distorts this interface during inspiration, and it is referred to as the Cardan sign. After identifying the liver and the kidney on the right upper quadrant, then we can evaluate Morrison's pouch for free fluid. The liver and kidney should be in direct contact with each other, and no black or anechoic space should lie between these two organs. Here's an example of a patient with a positive right upper quadrant. And notice the separation between the liver and kidney. The fluid appears collected in Morrison's pouch and between the liver and the diaphragm.
In this second example, we see a more subtle positive right upper quadrant FAST exam. There is a collection of hypoechoic fluid between the right kidney and the spleen. Rib shadows are making it challenging to see the entirety of the interface between the kidney and liver on this view. On this last example, we see another very clear presentation of a patient with a positive right upper quadrant with hypoechoic fluid collected between the liver and right kidney. Notice the sweeping motion of the ultrasound probe as it cuts through the kidney. For good measure, here is another example of a patient with a positive right upper quadrant exam. Here's another example.
Here's an example of a patient with a right-sided pleural effusion. We know there's an effusion because of the presence of the spine sign as a result of an enhancement artifact. We should not be able to see the spine above the diaphragm in a patient without a pleural effusion. The lecture on lung ultrasound explores these topics further. Some tips for right upper quadrant assessment include the following. If the rib shadows are prominent, the probe can be rotated counterclockwise, with the probe marker pointed towards the posterior axilla in what is known as the intercostal oblique view. This causes the footprint of the probe to be parallel to that of the ribs. The sweeping motion increases the sensitivity to detect free fluid. Left upper quadrant. The probe is placed in the posterior axillary line between the 6th and 9th intercostal space and indicator pointed cephalad. In a supine patient, it is difficult to obtain this view because of the axis the ultrasound probe needs to have, which may involve rolling the patient to the right. Here, we visualize the perisplanchnic anatomy and splenorenal fossa and corresponding diaphragm. Notice the echogenicity of the spleen and that of the left kidney. By moving the probe caudally, we can appreciate the inferior pole of the left kidney and paracolic gutter. Free fluid collects around the spleen and not necessarily between the spleen and the kidney. If rib shadows are prominent, the probe can be slightly rotated clockwise with the probe marker pointed towards the posterior axilla in what is known as the intercostal oblique view. This causes the footprint of the probe to be parallel to that of the ribs. This allows good visualization of the superior surface of the spleen and its lower tip, where free fluid is more likely to collect. A full stomach can give the appearance of fluid in the area, which is why it's important to move the probe posteriorly. We can also use the maneuvers mentioned above to visualize the left diaphragm and fluid collection above it. In addition, if there's a concern for a full stomach, we can do an interrogation of the gastric antrum to confirm our suspicion. We explored gastric contents in the gastric ultrasound lecture. Once the left diaphragm, spleen, and left kidney have been identified, we can evaluate the perisplenic area for free fluid. A positive exam is one that finds an echoic fluid between solid organs, separating the spleen from the diaphragm or the left kidney. Here is an example of a patient with a positive left upper quadrant. In this second example, we notice a few key features. There is an anechoic collection of fluid between the spleen and the diaphragm. We also notice a stomach that is distended as it lies in close proximity to the spleen. Finally, there appears to be a fluid collection above the diaphragm and an atelectatic lung floating in this fluid. We would have to move the probe upwards to confirm our suspicion. Suprapubic view. The pelvis is the most dependent part of the peritoneal space, and it is the most likely place to see abdominal free fluid. However, views are not easy to obtain. There are two planes in this view. The transducer is placed in the midline above the pubic symphysis in a sagittal plane with the indicator pointed cephalad. This is the longitudinal view of the bladder. It is then swept side to side. The second plane is one that is obtained after the probe is rotated transversely and corresponds to the transverse view. The corresponding 2D longitudinal and transverse view of a male in the suprapubic examination is seen here. The urinary bladder is identified in a near field. The uterus or rectum are visualized deep to the bladder and they appear hyperechoic. This is because of the fluid present in the bladder attenuates sound waves less than the surrounding tissue. This artifact is known as acoustic enhancement. We can also appreciate side lobe artifacts. Ultrasound transducer crystals produce a primary beam in the direction of expansion and contraction. Secondary beams occur as crystals expand and contract radially in what is known as side lobe beams and are less intense than the primary beams. When side lobe beams encounter a strong reflector, like the walls of this full bladder in this case, the strong returning echoes are displayed as though they are generated by the central beam. We appreciate this as an acoustic noise in the near field. Enough with artifacts, since we covered this in the physics of ultrasound lecture. We need to focus our attention to the presence of fluid behind the bladder or the uterus. Free fluid in the pelvis can be missed when a urinary catheter is placed, compromising the acoustic window for the suprapubic view. It is not surprising then that the detection of free fluid in the pelvis is aided by the presence of a fluid-filled bladder. When free fluid is present, an anechoic collection is most frequently located posterior or superior to the bladder and or uterus. Here is an example of a patient with a positive suprapubic exam. A trace amount of free fluid can be normal in the pouch of Douglas, depending on the female's menstrual cycle and corresponds to less than 50 mL, which is physiologic. Subcostal and IVC view to visualize the pericardium and IVC. Here is a reference clip of a subcostal view obtained with a curvilinear probe. This is the appearance of pericardial fluid. We covered pericardial fluid and tamponade in another lecture of this series. The EFAST includes the lung to rule out a pneumothorax. We explored the presence of a pneumothorax in the lung ultrasound lecture. For clinical decision making, hemiperitoneum usually appears anechoic or hypoechoic compared with adjacent solid organs as we have seen on these clips. With time, prolonged hemorrhage may organize and become more echogenic. The mean minimum detectable free fluid volume during a FAST exam is close to 600 mL in Morrison's pouch. It is important to note that once a view is determined to be positive, there is no need to obtain other views. As mentioned earlier, the specificity of the FAST exam is much higher than its sensitivity. CT of the abdomen will have better diagnostic accuracy for both blunt and penetrating injury, but the FAST exam is most useful in situations where the CT scan is not practical.
It is important to realize that the fast exam does not exist as an isolated evaluation, but one that can be done serially. In an active but relatively small intraperitoneal hemorrhage, the amount of free fluid should in theory increase with time. The initial fast exam represents a snapshot in time, and serial examinations may need to be performed. The sensitivity to detect free fluid increases from 69 to 85% when it's used serially. Serial exams are a great option for stable trauma patients, those patients with sudden change in hemodynamics or physical examination, and pregnant patients to mitigate the exposure to radiation.
A simplified diagnostic algorithm for FAST is as follows. Following blunt abdominal trauma, patients are divided into stable or unstable. Those that are deemed to be unstable and have positive FAST findings go to the OR. If they have a negative FAST exam, they may need to proceed to the CT scanner or have a repeat FAST exam or look for other sources and causes of hypotension. In the stable patient with an abdominal injury, the pathway is different. If the FAST exam is positive, up to the scanner to look for additional injuries. If negative, then several options are available. Observation, repeat FAST, contrast enhanced CT, or stop screening. Any of these has to be driven by a particular clinical circumstance. Clinical suspicion, mechanism of injury, and a change in the hemodynamic status of a trauma patient should take precedence in deciding on further diagnostic testing in patients with a negative initial FAST test. For the perioperative period, it is important to note the relevant past surgical history, since this may have an influence on our decision tree algorithm. Such is the case for patients who've had nephrectomies, splenectomies, or have a VP shunt, for example. Limitations of the FAST exam. Limitations of trauma ultrasound include the following. Technical obstacles that impair ultrasound performance, such as bowel gas in the near field, that prevents us from seeing deeper structures, subcutaneous emphysema, and obesity. The FAST exam has limited utility for detecting solid organ injury, especially in the absence of free intraperitoneal fluid. The same is true of bowel or retroperitoneal injury, as well as isolated penetrating injury to the peritoneum. False positives. Free fluid does not necessarily imply blood, such is the case in patients with ascites, ruptured bladder or peritoneal dialysis, peritoneal dialysate, VP shunt outflow, ovarian hyperstimulation, and ovarian cyst rupture. Massive intravascular volume resuscitation may result in a false positive FAST exam from the result of movement of fluid from the intravascular to the intraperitoneal space. The free fluid in the peritoneum may not necessarily represent hemoperitoneum, as is the case with injury to the bowel, bile, or urinary bladder, and spillage of their contents. And then we have false negatives. Clotted blood can generate various degrees of echogenicity and may be mistaken for normal surrounding soft tissue.
All right, so we're done with the FAST exam, focusing only on the abdominal components. Off to your next section.